Hi, everyone. Welcome back to Neurospicy Nursing. This is kind of part two of that cardiopulmonary lecture that I had, but more focusing on the respiratory disorders, and not just infectious, but all of the respiratory disorders. Um, I really want you guys to make sure that you know that it's our lungs, when we, let me back up a little bit. Nursing prioritization is ABCs, right? The airway, breathing, and circulation are the three priority problems when we are prioritizing our patients, right? So we have to make sure that we remember that patients who have respiratory issues are compromising their breathing. And if they have an infectious respiratory disorder, or illness, that can also compromise their actual airway. So make sure that you guys remember that as we're going through this. Okay, so one of the first ones that I wanted to talk about is going to be influenza. So it's really common, right? Every single year we get the flu shot to help prevent influenza. Don't forget that it is a virus, right? And the thing with viruses is that once we get them, they never leave our body. Even if we take antivirals, they never fully leave our body because they have now kind of edited themselves into our DNA. Also, make sure that you know and remember that there is a precaution for the flu. It's a droplet precaution. So surgical masks are what we're using. The flu is, even though we consider it a respiratory disorder, it can have systemic complications, right? Fever, tiredness, fatigue, muscle aches, those body aches that you get, sore throat, nasal congestion, and headaches, as well as cough, shortness of breath. You might hear wheezing. If they have fluid in their lungs, you may have crackles. Those are all signs and symptoms of the flu. So, because the flu is a virus, unless we can get, like make sure that we got them tested right away, antivirals like Tamiflu aren't going to be given unless they're within 24 to 48 hours of first symptoms. Because after that, it doesn't really matter. Um, So again, we're going to do the viral cultures. We're going to do rapid influenza testing to see and confirm that they have the flu. We can give them antivirals if they're within a certain time or if it's relatively severe case. Antipyretics are going to bring our fever down, and then we're going to give analgesics to kind of help with any pain or kind of muscle cramping that a patient has. The best prevention for the flu is, yes, do your annual vaccination, but wash your hands. Wash your hands. Best way to prevent any of these is to wash your hands. Also, if they are having difficulty breathing, we're going to elevate the head of the bed to high Fowler, so between that 30 to 45-degree angle. Also, we're going to give them support with oxygen. And whether, it's a nasal cannula or a simple mask, whatever, but if it's pretty severe and they need oxygen, we have to give it to them. It's a droplet precaution, so if you know that you're going to be within 3 feet of a patient, make sure that you're putting on a mask. And that goes for family too. And then hydration. Hydration is really going to help these patients. And a lot of times when we're sick, right, we don't want to eat, we don't want to drink, but by hydrating, it helps kind of like flush it out. You know what I mean? Helps you get rid of it quicker. All right. So COVID-19, it is also a virus. Both of those, by the way, are the flu and COVID are both mRNA viruses. COVID also has a injection similar to the flu where you get it every single year. To prevent it, make sure you get it. and make sure you wash your hands and make sure you wear your mask. Um, so this one is going to be a little bit longer than the flu, as in like the time in which you have it. The flu is relatively more supportive care. I know this year we saw a really increase in the flu being a lot more severe, but majority of the time it is supportive care. Pax or COVID also has a antiviral called Paxlovid. It's a combination of two different ones. But again, if it's not given within the first 24 to 48 hours of the onset of the symptoms, like when this person is having those first 1 to 2 days of their dyspnea, that it's not going to work as well. With COVID, it leads to inflammation and fluid accumulation in the airways and your alveoli. And also, it causes an increase in capillary permeability. So you may end up seeing pulmonary edema. One thing that you also have to make sure is that you're monitoring for pulmonary fibrosis. So in the case of COVID-19, you have damaged alveoli. That damaged alveoli is going to cause/lead to that chronic inflammation. And then because of that chronic inflammation, they have collagen deposits that are happening in their lungs, which lead to the thickening of the alveoli, and then eventually, i.e., you get pulmonary fibrosis. Again, pulmonary fibrosis is not directly from the virus. It is a kind of side effect of the virus. Like the virus is a precipitating factor, but not everyone who has COVID-19 ends up with pulmonary fibrosis. What's happening here is the abnormal tissue repair. Um, Another thing that you might hear in with COVID-19 is going to be called ground glass lungs. So this is a hazy film that happens when our alveoli are filled with those inflammatory cells as well as fluid. A lot of times, though, when we have ground glass, they're not fully filled, they're partially filled. Now, if it switches to consolidation, that's when the alveoli are completely filled with fluid and the inflammatory cells. And that's a huge, huge risk factor for developing something called ARTS. COVID-19 is not actually considered any of those but an airborne anymore, but it depends on your hospital. So make sure that you know that. But at Atrium, it's not even called that anymore. At our hospital system, it's just going to be a drop in precaution. A lot of times they were putting people in negative pressure rooms. It also depends on kind of what is going on with them. But something that we're going to do is a different position. So normally we have high flyers and that's going to help with oxygenation, but we're actually going to do proning in the case of severe COVID-19. When you think about proning, this is you laying on your belly, right? It's actually going to help with breathing. I know that you kind of think that's confusing, but there's a lot of organs in your chest cavity, right? In your thoracic cavity. And all of those organs sit on your lungs, right? So if we're sitting up, even if we're sitting in an angle, there's still pressure because we're not sitting straight up. There's still pressure on those lungs, right? And instead of us laying flat on our back, there's still pressure on those lungs. So by flipping them over, laying them completely flat, and putting them in the prone position, it gets all that extra pressure off their lungs and it helps them breathe a lot better. Other things that we have to make sure that we're doing with COVID-19 is preventing clots. So that could be from long term with no movement because of the fact that they had COVID-19, they have such severe dyspnea, or it could be sometimes too just because of dehydration, or just our blood can sometimes thicken as a side effect. So make sure that we're doing clot prevention. make sure you're moving them. STDs, all the things. If they need heparin or Lovenox, make sure that we're doing that. So I talked about complications. There's ARDS, there's sepsis, MODS, and long COVID. ARDS for testing your test purposes is probably going to be the most important one. Like your test coming up is going to be the most important one. ARDS is not respiratory failure. ARDS can lead to respiratory failure. It in itself is not respiratory failure, and it's a lot more easily reversible than respiratory failure. Now, they may need mechanical ventilation for this, or they can use a CPAP, BiPAP, non-rebreather. But basically, when we have ARDS, it is pretty severe low oxygen, so your PaO2 in your blood. So you should be doing, hopefully, right? If they have a ABG line, you're doing arterial blood gases, and you should be able to see that with ARDS. Also, make sure you know respiratory acidosis is something that you're going to see in ARDS. And if respiratory acidosis gets worse, it can cause lactic acidosis, which can lead to your multi-organ dysfunction syndrome, which ends up being metabolic acidosis. It's a lot. They're all acidosis, though, so you should be good. Okay, so pneumonia. Multiple different types, right? There is viral, fungal, aspiration, community acquired, hospital acquired, ventilator associated. There's a lot of different types of pneumonia. And there's also pneumonia there's like saddle pneumonia, which happens like in the middle of your lungs. And then there's one that only happens on one lung and full, like both lungs. But it's a very, very common condition, right? Like it just is common. Pneumonia is inflammation of your lungs that has been caused by a pathogen in the lung, which then leads to an increase in fluid in the lungs and then poor gas exchange. You can see pneumonia on a chest x-ray. Now, in order to figure out whether it's fungal, bacterial, whatever, you may have to get cultures for that to make sure that you're giving the right medication. Viral pneumonia is also going to be supportive care, and a lot of times they get it from like COVID or the flu. But they're going to need supportive care, and if it's severe, we'll give them the Tamiflu. And if they've gotten the pneumonia, I mean, yeah. So if the pneumonia is also within like the first symptoms, they can treat it within 24 to 48 hours, and we'll also do the antivirals. The other thing that I want you guys to remember, if somebody's having chronic inflammation from the pneumonia that's been lasting a long time, we may see them go home on steroids, like a steroid pack, Z-Pack. And while they're at home, and not at home, in the hospital, and sometimes at home if they're asthmatic, but if they're in the hospital and they're not asthmatic, respiratory therapy may still end up giving them nebulizers just to help kind of open up their lungs. Whoops, sorry. Things that are going to be super duper important when we're thinking of our respiratory conditions. Respiratory rate. Is it too low or is it too high? You know, that's the whole alkalosis, acidosis for the respiratory. Are they hyperventilating? Sometimes in pneumonia, someone can start hyperventilating. and they're hyperventilating because they feel like they can't breathe, and then all of a sudden they're crashing. So that's something else to think about, right? Are we skyrocketing in respirations because we can't breathe and we're about to tank? Or have we already tanked and our respirations are at like 8? Um, Also, it's going to affect our heart rate. You may see them end up with some sort of arrhythmia because of this. And that can be from the medications like the albuterol, or that could be because their body is trying their best to perfuse. Um, they can have fevers because of the bacteria or because of the virus. Um, You're also going to monitor their SpO2, their PaO2 for really intense hypoxemia, which is a low amount of oxygen in the blood. You're going to monitor their CO2 levels to make sure that they don't have hypercapnia, which is too much CO2 in their blood. And then we also want to monitor their hemoglobin, hematocrit, because it's going to be affected by the respiratory conditions. And once those stop dropping, it's kind of a sign that they may be becoming septic, like the bacteria is kind of overloading all the other cells in the body. And then we're going to watch their electrolytes as well. So, again, like I mentioned before, we're going to use bronchodilators to open their airway, like when they're in the hospital, those nebulizer treatments. If it's bacterial, we'll give antibiotics. Virals are mostly supportive care, and then fungals will give antifungals. Um, Other things that we're going to do, if they are vented, lots of mouth hygiene. So we're gonna do all the oral hygiene, brush their teeth, all of that section. We're gonna increase their fluid intake to help thin out that mucus that they have. Um, and humidified oxygen, if obviously if they're not vented, right? So again, sepsis is a kind of a side effect of pneumonia, and bacteremia is just a lot of bacteria in your blood. And then acute respiratory failure is also a complication. ARDS is also a complication of pneumonia. Tuberculosis. So TB is one of those conditions that if you have active TB, health department can actually forcibly get you treated because of how like the way it spreads is just so like it's such a rapid spread. In order to see active TB, you need either positive skin test and positive chest x-ray, or a positive blood test and a positive chest x-ray. So the chest x-ray will always be positive in both. Majority of times we can have false positives in the skin. So if the skin is positive, they may do a blood test and a chest x-ray just to make sure and rule out. And that also can help us determine whether or not it's latent or not. Latent TB, positive skin test or positive blood test, but you will have a negative chest x-ray. They are not infectious. These are not the ones that we are forcibly getting treated. That's active TB. Something that you're going to see with TB also a lot is going to be night sweats. So your patient's going to come in and they're going to be complaining of a cough, of anorexia or weight loss, of a lot of fatigue, and just this excessive amount of sweating while they're sleeping. Test them for TB. Don't forget, TB is also a contact precaution. And an airborne, sorry, just kidding. It's an airborne precaution. So these patients are going to be in your negative pressure room. You got to wear a N95 mask. And there are certain populations that are going to be more at risk for TB. And it's just people who have lower access to healthcare / those who are immunocompromised. So here is the little photo of a skin test. So Um, again, they kind of break it up like the measurement. They break it up a little bit because if you are HIV positive, you can end up with a quote unquote false positive of the skin test. So these are just like the first two are going to be kind of we'll see it on their chest X-ray. Like it's not necessarily abnormal for them. Now, if it's greater than 15 mm, that's definitely a concern. Like anybody at this point, it doesn't matter if they are incarcerated. It doesn't matter if they are HIV positive. They have a positive skin test. If they have anything over um, 10 to or anything over 15. When we get into the 10, like it's just a lot more positive. Like the size of it is going to be there. I mean, it doesn't like necessarily mean, I mean, yes, they're positive. Let me back up. They are positive if they're in these categories, right? And it's 10 mm. They are positive for, they have a positive TB skin test if they have HIV and it's greater than 5 mm. If it's lower than 5 mm and it's still there, it could also just be because they have HIV. I hope that makes sense. I'm probably not doing a very good job of explaining that. Okay. And then there's 4 medications that you take. It's the RIPE protocol. Don't forget that rifampin, it can stain everything red. So we're not going to put in contacts because it's going to stain them red. And also tell them that because if all of a sudden they're peeing red, they're going to be so confused or they start crying and they see red, they're going to think that they're bleeding. Please tell them. Please tell them that that is a side effect of that medication. Again, it's an airborne precaution, so closed door, negative pressure room, and then the patient has to, while they are being transported around the hospital, has to have a surgical mask on. And this is just making sure that they adhere to the medication for, because again, it's the one that you can be forcibly treated for. So after they take their medication, just, well, one, never leave them alone in the room with the medication. Make sure you physically watch them take the medication, and then have them open their mouth just to make sure that you saw them actually take it and lift up their tongue and all of that. Here's a different type of precautions that you're going to need for the different, well, things that we discussed, I guess. And then here's a little case study. You guys can do that if you want. Pause the video here if you want to do that. And then other things. So when we're evaluating our outcomes for our patients and, we're getting ready to discharge them, we're changing our care plans because they're now doing better. These are things that we want to see, right? We want to see an improve in gas exchange. We want to see that if they're vented, we want to see them to be able to get off the vent. Infection clearance, we don't want them to be able to see anything else in the chest X-ray. We want to see a decrease in our white blood cells and a decrease in our fever. We want to see them be able to start eating and drinking again, right? And maintaining a stable body weight. And we also need to make sure that they understand the purposes of the medications that they're taking and why. Okay, and that's all I have for you guys. I should be uploading a video tomorrow, a little bit about MedMath. So make sure that you stay tuned for that. I was gonna do it today, but my voice is kind of going, and you guys know how my voice is. But yeah, just if you have any questions, write them in the description box, and I'll get back to you. All right, that's all I have for you guys. Bye bye.